Welcome to the Dr. Ed Show, where we focus on health and your wellness. I'm Dr. Edmund Sulkowski, your host. You know, you can hear me live every Saturday morning at 9 a.m. on AM 1250 The Answer for my radio show, the Dr. Ed Show Health and Wellness. And you can also follow us on rumble.com, Spotify, iTunes, TuneIn. We're all over the place these days. All you have to do is search, subscribe, and share. Now, we have a wonderful show today. I'm so excited to bring, and in the interest of disclosure, we got to use those words today. My guest today is a patient of mine, and I'm a patient of hers. Let's welcome today Dr. Rebecca Plute. Welcome to the show, Dr. Plute.
Thank you, Ed.
You know, I'm so excited to have you on here. You're just a unique in the world, in the field of medicine as a physician. So I'd like for you to give the audience a little bit about your background. Okay. You have a medical degree from?
Medical College of Pennsylvania.
Which is a fantastic school. It's eastern part of Pennsylvania.
Yes, in Philadelphia. It's actually evolved too, and it was the first women's medical college in the country, and then became co-ed and was the Medical College of Pennsylvania, then was joined with Hahnemann University and is now Drexel Medical School.
I know that area well. I actually lived in Philadelphia and spent a year at Temple, and it's kind of how I describe it. And Philadelphia's an interesting place, and quite different than this area. But they really focus on education in that area. The number of universities there.
Yes.
Medical schools, undergraduate schools,
private schools,
business
prep
schools. It's amazing. Yeah. And so you practiced for a number of years in a hospital setting as a physician. You don't do that these days. You're a concierge physician.
Well, I do still round at the hospital. I still have, you know, many people are using hospitalists now, and we'll get a chance to get into that. So I was an employed physician, which better than 80% of primary care physicians right now are employed physicians.
Yeah, there was a big change, and it's happening clear across all aspects of medicine these days. And physicians used to be private entities, and then they became employees of hospitals as hospitals bought their practices.
Right, hospitals and other organizations. I specifically was owned by Centerville Clinic. Well, I worked for Centerville Clinics, which was founded as a miners clinic in the 1950s, the Yablonsky Memorial Clinic. Wonderful organization that serves the underserved, and I worked there from 2001 until 2015, and I had served in several of their offices. And during that time, a lot of people were noticing that problems were happening in medicine. You know, there had been, you know, traditionally private physician-owned practices, and in the 80s and 90s, hospitals started to buy up referral bases, make very attractive deals to physicians to sell their practices to them, and then other organizations, you know, to take care of the Medicaid, Medicare populations, such as Centerville Clinics, also begin to employ physicians and buy their practices. So you have this big shift of physicians becoming employees instead of practice owners.
And I can actually remember the days when a physician came to your house. I remember my grandparents' physicians coming to the house as a little kid. That's something that you don't even hear of today, except for...
Yeah, I occasionally do that. I occasionally do that for my patients.
So you're owner of Paragon Personal Health Care, and you're located in Canonsburg. And what I love in the title of your practice name is the word care, because I think people confuse health insurance with health care, and there's a big difference there. Would you define that for us?
So it's interesting. I love human language on so many levels, and you know this because of many of our conversations. But we call it medical care because the caring is such an important part of that. And what has happened as larger organizations have tried to fit everything into algorithms, we've lost some of the care along the way. That it's a very manufactured kind of process, a one-size-fits-all, and whereas the human body and individuals are unique. So I believe in a much more individualized, customized approach. And like any other craft, that takes time, and it takes getting to know people, and it takes building a relationship.
Well, and I think that's critically an important statement that you just made. Getting to know your patient, getting to understand their needs, and then you can plan a care protocol for them.
Right.
And I know I have a lot of friends that are physicians, and they're working for these hospitals, and they have time limits that they can see their patients with. They're constantly under the gun of meeting numbers. And in the meantime, they're trying to do what they were taught to do, and that's take care of the needs and health care of a patient. And when you have time restrictions on there, that becomes a problem. Or if you're dictated to by what an insurance company wants you to do, there are issues there. And I think the only way that you can overcome those is by having someone like yourself, a personal concierge physician, because you're willing to spend the time to get to know your patients and get to know their needs.
Right, and because I'm the owner of the practice, I am able to manage the schedule in a way that makes sense for my patients' needs. When a physician is employed, an administrator sets the schedule. How often are patients going to be seen? What number of patients are going to be seen?
And even they have difficulty getting lab tests ordered because of the insurance. I know even in my practice, when I do certain protocols, certain procedures, I have to go by what the insurance company has established as the steps. That sometimes doesn't benefit the patient because, say, a patient's on a pre-med for something, and I could do that procedure all in one day, meaning that they only have to be on that antibiotic for one day, but because the insurance company dictates how that procedure is done, I have to bring him in over 3-4 days where we're constantly putting him on an antibiotic as a pre-med. And so it doesn't make sense, but that's what happens when you have an insurance-based program.
Right. Well, when it's a one-on-one program, right, it's between me, the patient, and they're the one paying for my service directly, not the insurance paying for my service. They can make a decision if this is a valuable relationship, if they're getting out with it. And that's how they determine the quality. Whereas an insurance company who's a third-party payer who's not there at the time comes up with a bunch of codes and quality markers and algorithms to figure out indirectly if you and I are doing a good job.
Yeah, it's
right?
amazing.
And I'm sure that much of this is good intention, that some paper somewhere said, well, maybe this is a better way to do it, and maybe it's a better way to do it for 65% of the people, but maybe it's not the right way for the patient in front of you. And again, it just becomes, as the further away that the third-party payer is, the less that they're invested and know what's going on, right? They want to take care of a large group of people, but you and I are taking care of the individual in front of us next.
Well, it's exactly it. But I think sometimes it's the insurance company's bit of a wall, because their idea is to take a premium from you and try not to pay for a service. I mean, that's really, I think, what's in the back of their minds over there. They want to hold on to that money because they're investing it and doing whatever they want. And so the more they have to hold on to invest, and the less they pay out, the better off for this corporation. And, you know, I had an example that I can state that just happened last week. A patient came in and she had infected tooth roots that needed to come out. And so they were taken out, submitted to the insurance company for payment, and they denied payment because I had to justify why I took out these infected. I had to write a narrative. They were submitted x-rays. They were, you know, anybody could see what the problem was.
Right.
You know, because they have doctors looking at these x-rays. But in order to delay the payment, they come up with this, oh, you got to write a narrative why you took out these infected root tips. you sit there and you just shake your head.
Right.
You know, because you're spending time to do that.
Instead of time taking out the next infected roots that you see.
Exactly. And so to me, that's a problem. And I think people confuse the term. They have health insurance and they think that's health care, and it's not.
Right. Well, and some of it's aptly named, right? Some of it's called managed care. That's what they're doing. They're managing the care.
Yeah.
But not the care part of it, right? They should just call it medical management.
Medical management.
Right.
Yeah.
And again, it often ignores the whole person, right? So I'm very much the whole person. We've talked about mind, body awareness, what you're thinking, how that affects your health, how it affects your health-related behaviors, how it affects your ability, if you do have a chronic disease, to successfully manage those problems, right? There's so much piece to there, but the insurance company, again, is all going to be based on actuarial science. What do the numbers say? And it becomes a very cog in the wheel process. And for me, my experience with the cog in the wheel process was a lot like Lucille's ball in the episode I Love Lucy, when her and her friend went and got hired at the chocolate factory.
That's a great one.
Because I felt things are coming down faster and faster in life, and I'm trying to do each one perfectly and neatly and take care of that person, but things are falling off the conveyor belt, and this is people's health and their wellness that we're running down the line too fast. And I got to the point where administratively I participated in a program to enhance the organization and the teamwork aspect, and many of those elements of the program were great, but the chocolates were still coming down the line really fast. So that's when I made the decision, is I don't feel like I'm providing the best care that I was created and designed and trained to be able to provide. I need a model where I end the day feeling like I did a good job. I genuinely, emotionally was able to care about my patients and be invested in the outcome. I had time to listen to their concerns and find out what things are most important to them. And we collaborated and came up with a plan together. You know, it was interesting in that project. One of the goals was have the team collaborate and have the physicians collaborate with the patients. But extra time wasn't built into it.
Yeah, and it becomes difficult because you're, a physician, doctor in front of somebody's name means educator. That's what it means. And you have to educate your patient as well as treat them. And that's not an easy thing to do.
It is. In fact, it's an extremely thrilling, joyous experience to be able to sit there and talk with a patient and have them bring to you what they may have read on the internet or what their family had told them or what they came, and you work with them, find out where their knowledge base is, and they can further their understanding of what's going on in their body. And you know when the brain is happiest? The brain is happiest when it's learned something new.
Yeah.
And it becomes invested in making wiser decisions and having better discernment. And this is the best we can be as people.
You know, on the radio show and on this show, and I don't say it so much on this show, but the opening on the radio show is we don't treat or we don't diagnose, but we educate and inform to make you empowered about your own health and wellness. And I think that's exactly what you do in the office. I know that's what I try to do. Not always 100% successful. Sometimes patients don't want to hear it. They just want to come in and get the procedure done and be done, let me out of here, kind of deal. But there are patients that take an active role, and I think those are the most successful patients in their overall health and wellness, when they're active.
Right. And those are also the kind of patients who frequently will seek out concierge medicine, because in that, they waited 6 weeks to talk to the doctor and they have all these ideas and all these things, and the doctor says, oh, we only got 10 minutes, and they waited 6 weeks to get that appointment.
Or longer,
Yeah, and again, they're just being rushed through so fast that they're not necessarily getting to go through the learning process that they were completely ready and primed to engage in. And to me, when I felt, when I was in that system, that I was brushing somebody off who was really about to engage in a learning process that was going to improve their overall health for the rest of their life, like, I was cringing. I'm like, I don't want to let this moment go. And so sometimes I would spend that extra time, but then I would get an hour behind in my schedule. And I love to help people learn things because I'm a doctor, I'm a teacher, right? As you said, that's what the word means. I don't like to be late, though.
Yeah, I know. And it's easy for that to happen. It really sometimes only takes a patient being 5 minutes late to really mess up you at the end of the day.
Well, Again, when I was in that model, it did, and
Yeah.
much more so now because of the expanded time slots that we have to address people's needs. People don't have to be stressed if they're that 5 minutes late behind, what, a backhoe?
Well, that
Right?
can
They
happen.
know that
Yeah.
that when we get there, I'll still have time to talk. And if we don't have time to finish it, maybe we'll carry on the conversation later that day when I have a few minutes between other patients, right? That we don't have that time limit, that I am accessible to my patients.
So you were in this traditional practice,
Mm-hmm.
and there's a sense of being comfortable in that practice. You have a place to go to every day. You have a patient load. You have all those pieces of the puzzle that are in place,
Mm-hmm.
and you do your job, and then you go home at the end of the day. Was there a aha moment one day that you just said, I can't do this anymore, or it was just a gradual buildup of the situation?
I think there was something always there that, oh, there could be a better way to do this, right? I was very busy when I was in one office, and then went to a more rural location where I got to enjoy that time really educating patients and spending some time. And then I got a nurse practitioner to work with it, and we were very much on board about improving the health of the people in this area through education. And the results we started to get by spending that extra time was absolutely amazing. We had a whole family stop drinking 32 ounces of sweet tea, and just because we convinced one person to try that and see how that affected her weight and her metabolic state, and she got great results. And then her sister said, well, what's she doing? She's like, I don't know, you gotta go talk to Dr. Plute and Carla. And pretty soon we had this entire family and their friends on board with us, and we saw 12 people's hemoglobin A1Cs go down and their diabetes control improve. And we're like, wow, it's worth spending time with people.
Yeah, you know, everybody's marketed to on TV,
Mm-hmm.
and people don't understand the consequence of sugar overload, carbohydrate overload,
Yeah.
and what it does to even your mitochondria,
Mm-hmm.
and what it does with brain fog, and
Mm-hmm.
you name it, and it does it. And everybody, you know, you get overwhelmed with all these commercials and so forth, and everybody's doing it, so why not?
Well, and
Yeah.
I think that is actually one of the fundamental problems with our healthcare system, besides all the fragmentation and everything else we got going on, is this process. People are not always ready to hear, right? But this process of educating requires time. In the conventional medical model, it's faster to write a prescription and band-aid that little problem than go to the roots and really help that person learn how to manage, how to prevent complications, how to get healthier. So the whole model has written off, you know what, we just need doctors to see people, write those prescriptions, get them out the door, and bring them back and see them again and write some more prescriptions without ever really addressing what we could do better.
Yeah, without addressing what I call the root cause, and I think that's what is often
You say that because you're a
overlooked.
dentist.
Yeah. You like that? Never kind of looked at it that way, but yeah, you know, you have to look at what's causing it. You know, when I was helping out with a thyroid practice, no one ever looked at the liver, and they would have thyroid issues, the signs and symptoms of thyroid issues, but the thyroid was fine.
Mm-hmm.
The problem was the liver. You weren't metabolizing the conversion of T4 into T3 and then bioavailable T3. So, you know, you can give all the thyroid medication you want to give, and it's not going to work because of that, because it has to be metabolized in the liver. So, people walking around with liver disease, you know, cirrhosis or fatty liver disease in a sense, have that problem. Yet, you can transform the function of your mitochondria by clearing up the process of the liver.
Mm-hmm.
And people say, well, there's no cure for fatty liver. Well, there is. Cut out the carbohydrates, do a keto diet for 3 weeks, a month, or whatever. That'll reduce at least 50% of the fat in that 3-week period. And then you might have enough healthy cells, because the liver regenerates, to go ahead and convert that T4 into T3. So there's all these aspects that get overlooked in that model of what you just said. Come in, write a script, see you in 6 weeks or 6 months or whatever it is. So I think more and more what's happening is the medical profession is gaining some speed here in looking at that root cause and looking at the whole person again. I mean, that was the way it was years ago. And I think that's starting to reverse again, because people are seeing results when they have a physician like yourself who's attending to their needs. So Paragon Personal Health Care in Canonsburg, that was, I think, a big step. I've never had that conversation with you, but I would see it as a big step, leaving that original model and going on your own and opening up this practice. Why did you pick Canonsburg?
I went to high school in Canonsburg. My parents went to high school in Canonsburg. It's an amazing town with amazing people. It's centrally located. It's off the interstate. We have chocolate. Sarah's chocolate, right? We have Sulkowski's dentistry.
Yeah,
we have a lot of good things going on in Canonsburg.
Jeffrey's Pharmacy, you know. Writing scripts all the time. When I have to call some of these big box pharmacies, I cringe, because they're just a nuisance. But you call Jeffrey's, and it's that hometown pharmacy.
So Gerard O'Hare, who owns Jeffrey's, is a great personal friend. And when I was beginning to consider to do this, he had just bought the building that we're in, needed the central section renovated, and he says to my husband, who was helping my father-in-law was helping Jeffrey's with some work that they were doing to get the place ready to open. He said, you know what I would really love? I would really love to have a physician in the building. And my husband said, you know what I have? I have a physician that's really looking to open a private office.
Gizmo, huh?
Some things are just meant to be.
Yeah, and it's worked out well, I know. So I'm in this particular model now where I'm seeing a general physician, and you're a family physician, correct? You see all ages. That's a rarity by itself anymore, because everything is fragmented and everybody's has a specialty practice anymore. How do I go about switching from the model that I'm currently in to becoming a patient of Dr. Plute's at Paragon?
So one of the exciting things is I'm not the only option in the area, and like across the country, it's been steady for about 20 years now, of 6 to 7% of patients switching over to that concierge model. We estimate right now that there are 12,000 physicians in the country like me, maybe more, taking care of over 300,000 patients successfully. So in our practice, someone would look at my website. We have pricing transparency there. You can go on the website and know what this will cost you monthly or annually. And then you read about what I do, what my accessibility is like, how you get in touch with me in an emergency. All that's on spelled out on the website. And then an individual can call Melissa, who's my office manager, or they may get Melissa's cell phone coverage, or they may even get one of our estheticians, but they will not get a phone tree. And then schedule an appointment to have a conversation with me to see if it's a good fit. There's no charge for that appointment. And then if we feel that my way of managing things and the potential patient's way of managing things are well aligned, and that we feel that we can work together and build the right kind of therapeutic relationship, then we move on and that patient enrolls in the practice.
So what services do you provide?
In office, we do all the regular medical care.
So you're looking at blood tests, you're looking at x-rays, your patient comes in with signs and symptoms of certain issues. You're doing all the diagnostic work just like any other practice would.
Right. Now, we don't have x-rays in our office. We do blood draws and we send to a lab.
But
And the lab services are covered by their insurance. Their services that I'm giving them, the physician's charge, isn't billed to the insurance.
Right. So you're providing the orders for the diagnostic work, and that's still covered by whatever insurance
they have. And we send them to facilities that are, of course, we check which facilities are par with our insurance, and we send them to the appropriate facility. Occasionally we have someone who has no insurance or has unique types of coverages that are out there for people who do not engage in the traditional insurance model as it is right now. And an increasing number of facilities are also having direct patient care services where there's a transparency in the pricing and people may pay out of their own pocket or use a non-traditional type of insurance to cover those services.
Our mutual friend Tom Jacobin at West Penn Life and Health always talks about that.
Yes,
you know, sometimes it's better for you to pay out of pocket at these certain areas than they even use your insurance because your copay is higher than what you would pay because there's different setups that have been established.
Right. And
so it's kind of interesting that you really have to know that medical model, and that's what shows like what I'm doing. Hopefully is educating and informing that there's something out there other than that traditional model that everybody has fallen into. So the first thing we do is go on your website, ParagonPersonalHealthcare.com. I get that right?
Yes.
And just read about you.
Yes.
It's all spelled out. I've been on the website, and then if you think that Dr. Plute can be helpful, then you just give a call. So, you know, Dr. Plute, we have a break coming up, and when we come back, we're going to delve a little bit deeper into the different services and hopefully a few other things. We'll be back at the Dr. Ed Show with Dr. Rebecca Plute. Welcome back to the Dr. Ed Show. We're here with Dr. Rebecca Plute, and we're talking about health care. Dr. Plute, you know, I'm fairly healthy. I take care of myself. I try to eat right. I try to exercise daily. I, falter every once in a while. I take healthy supplements. I feel that I should be in charge of my own health and wellness, and that's something that I preach. But, I like an annual physical. Am I able to come to your office and have an annual physical?
So that's part of our membership plan, is that all of our patients are able to get that physical. Included in that physical, we have EKG, pulmonary function test, and just baseline EKG. Most things in insurance, to get them paid for, you have to have something wrong. Right? They do a few things preventative like mammogram and colonoscopy, but even colonoscopy was a fight for a couple decades. But mostly you have to have something wrong. We like to get an EKG and a pulmonary function test, baseline heart and lung function, so that if you ever do experience problems, we can figure out a little quicker what has changed. And that's part of the physical. We also do a vision screen, a hearing screen, all of the routine vitals, a health assessment, what do you feel is going on with you, what are your health habits like, and that's all a one-on-one conversation with me. And then we, at the end of the physical, decide what is appropriate blood work, both preventative and diagnostic, to order for you. So that's all included. It's called an executive style physical, and it's part of the membership plan.
You say the word executive style is because sometimes when you work for a corporation, they require that annual physical every year,
right,
in order for you to maintain your employment. And that's probably a good thing, because sometimes you can find things that you're not aware of because you're not seeing signs. High blood pressure, you may not see a sign for a long time and have hypertension.
Right.
And so where that annual physical comes in, or even issues with blood work. If you're not once a year doing some blood work, then you may miss something that's happening inside your body. So that annual physical, I think, is actually good. We call it, what, a wellness physical? Mm-hmm. Yeah, yeah, mm-hmm. Important. So is that the general way that I come into your practice, or is it I call up and I say, you know, I've been having these headaches, or I've been dizzy, or, you know, my foot hurts, and that's how I come in?
Either way.
Either way.
Either way.
All right. So what would be the first length of time that I spend with you in your office on my first visit?
So the first thing we do is the interview visit, and that is typically a half hour, 45 minutes. Do you think this practice is right for you? Do I think that I can help you meet your goals, right? Are we a compatible partner? And then after that visit, usually it's an hour of me going through your health history, and if your health history is short, then we get to talk a lot about philosophy, what your goals are in your life, what you're going to be using your body for, and how to keep it in that kind of good condition. And if you have underlying things, we start to evaluate how well are we doing with those things, and where can we make improvements.
So do you talk about medications that a patient might be taking, mm-hmm. that somebody else had prescribed, and mm-hmm. why they're taking them? You talk about like family health history?
Yes.
Why is family health history so important?
Many things are genetic, and many things are social cultural, right? So whatever environment we grew up with, our family, and this is great about being a family doc, right? There are things that quote unquote run in people's families. And again, some of those run in people's DNA, but some of those sometimes, like our relationships with alcohol, or our relationships with food, or our relationships with exercise, or how we handle depression, or how we handle an anxious thought. Many of those things come from what we've learned from our families. So the family history is so important in finding out a little bit of what did you start out with to get to the point you are with your overall health right now, and sometimes can give us clues when we would like to make some positive change or build on some positive things that are already happening, why they are the way they are.
Hey, do you hear what I hear in practice? Sometimes I'll have a patient come in, and they're younger patients, and they're not taking care of their oral cavity. Mm-hmm. They'll have gum disease, mm-hmm. tooth decay, whatever. And they'll say, well, my grandmother had dentures, my mother had dentures, and I'm going to have dentures too. And I go, no. They'll say, well, that's genetic. And I go, well, very rare is it mm-hmm. actual genetic. It's more of an epigenetic thing. You may have a genetic code that you're predisposed for something, mm-hmm. but it's much like taking a key and inserting it into the lock and turning it. Mm-hmm. If you're not inserting that key and turning it, then those things aren't going to manifest. And the problem is not that Grandma had dentures and you're going to get them. The problem is you're not brushing your teeth or flossing or having the oral care that you need to maintain your oral health. Do you get things like that all the time?
I do. And when I do, I think it's a great opportunity, right?
To educate.
Is to change people's paradigm and educate. And for many people, yes, it might be diabetes, it might be my grandfather and father both have kidney failure, I'm going to get kidney failure too. And I'm like, oh, but that's why you're here today, so that you don't, right? That's why you're seeing me, so that we can discover the underlying causes and take a different fork in the road, right? That's why you're here.
So the traditional medical model, in my opinion, is a reactive model. Mm-hmm. You wait for the disease to surface, and then you try to treat it one way or another. It's what I always call Frankenstein medicine. And yes, I did coin that phrase 30-some years ago. It's where what I was trained, what you were trained. Mm-hmm. You cut it away, you sew it back on, or you suppress it. That's how they made Frankenstein, and that's why I named it that.
Right.
So my approach to life is a little bit different. It's a preventative care. Mm-hmm. So I say that people cause themselves to be insulted. They insult. Mm-hmm. And that insult leads to a disease process. If you stop the insult, your body knows what to do.
Oh, it's amazing.
So what is preventative care for you?
So preventative care, and it can be quoted out there that a good physician does a good job treating the disease and giving the right prescription for the ailment. A great physician sees the disease coming a mile away and prevents it from ever occurring, right? Now, the trick is much of our preventative stuff has to do with people living more sensibly and rationally, right? Sometimes people are living irrationally because they don't know, right? They just haven't learned. You know, if somebody's been manufacturing Twinkies and Tasty Cakes and for 30 years this was perfectly acceptable food, not realize that they had a metabolism that was going to take that and fatty up their liver and cause insulin resistance, right? Sometimes they just need to know better and make a change. Sometimes it's an addiction or a compulsion, and making that change is a lot more challenging.
Right.
But there was a physician in 1200 AD, Maimonides, who stated that only one death in 1,000 was due to natural causes. The other 999, irrational living, right? So a lot of this does become, and I think that the more people know, the more empowered they are to understand what's really happening. I will often pull up pictures on my computer and say, this is what's happening. I did that just the other day with somebody trying to understand their ear infection, whether it was a middle ear or inner ear infection or an outer ear infection. So we pulled up a picture of it and we looked at it, and I said, here's where the problem is. Here's why you have this. Here's how it happened. Here's how we're going to fix it this time. And here's how we're going to take steps so that it doesn't keep happening.
Doesn't happen again.
Right.
Exactly. Removing the insult.
Yeah. Removing the insult.
Yeah.
Right.
So, and that's sometimes a hard thing to get across, because people have bought into this, give me a pill and
right.
see you
American
later.
medicine sold itself so well. We've got a pill for that. We've got a procedure for that. We could fix that.
Yeah.
Right. It sold itself really well, but I often find that people's frustration is to the level sometimes when they're contending with the fact that the treatment didn't work, or that they're in a position that there is not a treatment. Because this is surprising to them, because we have done such a great job of selling the modern miracles of medicine, and they are miraculous. Have we ever talked about Rogam?
No, let's talk about it.
We'll talk about Rogam.
Yeah.
Sometimes people question if we live in the best time slot in the history of humanity or not. We do, right? So I'm Rh negative. My husband's Rh positive. I have 5 perfect, healthy babies. In other time periods, before the 1950s, women who were mismatched to their husband might have 4 stillborns. I have an elderly woman in my practice that never had a healthy baby because of Rh mismatching. And I got this Rogam every time I got pregnant, and that prevented my immune system from seeing a baby's blood type that was different than mine, right?
That's
like,
what
that's
creates
miraculous.
what some people call blue baby?
Yes.
Yeah.
Yes, you haven't heard of it for a long time.
No.
Because it's interesting, as much as there's a lot of different procedures, techniques that are controversial, does this vaccine work, does this not nobody's ever questioned Rogam. Everybody loves Rogam. In fact, the Jehovah's Witnesses, when Rogam was about to release, pre-released a statement that this was not considered a blood product or something that their members consume. They endorsed it fully.
Yeah, because their religion doesn't accept any blood transfusions.
Right, right. So Rogam, fascinating thing what it is it's the antibodies that my body would have made if it had seen that Rh positive baby's blood. It just puts the antibodies in ahead of time, so my immune system doesn't see it, and I never become sensitized to it.
Yeah.
It's an amazing, beautiful human understanding of how the body works.
And I think that's the key. And some physicians just buy into that model that I call Frankenstein medicine, and they don't want to look, you know. I think I'm a prime example of it. When I went through all of my issues and my surgeries and was told go home and get your affairs in order because nothing we can do for you.
Wow.
And then I started doing things on my own. And that's a whole nother 10 shows.
Oh my gosh, yes.
But
we have to talk more, because I thought I know so much, but there's so much more to learn about you.
But when I would go back, and there was a 5-year, this is no exaggeration, and you know how hard this is, 5-year period where I saw 3 physicians a month, twice a month.
Wow.
Which was basically every 4 days I was at a physician's office.
Yeah.
And I learned 5 years later by my main physician, who said, you know, I did nothing for you, you did it on your own. And every time, this is the first time in 5 years that after you left my office, I thought that was the last time I was going to see you.
Wow.
And you sit there and you look at that realization that every time I saw this guy, which was at least twice a month, I think I saw him a little bit more, he thought that was the last time I was going to be walking into his office.
Wow.
So the reason I'm even mentioning this is because that philosophy was, I don't know what you're doing, but whatever you're doing that's working for you, keep doing it.
Yeah.
But they didn't want to hear what I was doing. They didn't want to know what supplements I was taking or what forms or how I was doing it. It was not the medical model. And that brings up what I want to discuss now. So we have billing codes.
Yeah.
And if there's not a billing code for a disease, there's no payment for treatment of that disease.
Right.
Or there's basically no disease. So they sit there and say, okay, you have a diabetic, full-blown diabetic, we have a code for a diabetic, and a treatment for a diabetic. You know, metformin, whatever it is. But a pre-diabetic has no code and no official treatment. We have to wait for you to become a diabetic before we can treat you.
Right, and that's very true in the psychiatric world, right? If I see somebody that's struggling to manage their stress, right? I can't say I saw him for stress management and bill the insurance company and get paid for that. But if I see somebody and say, I'm going to label you as having a DSM-6 major depressive episode, and I'm going to put you on a drug, I'll get paid for that. So what if I would like to make a living in that model? So if I help that person not get depressed and give them the right kind of resources and help them with the support system, I'm never getting paid. But if I just wait until they crash, I can get paid.
Well, it's all aspects of medicine.
But plus, then I have to like cover their health record, which might affect if they could get, you know, life insurance or health insurance in the future, by saying, oh, you have this major depressive episode that 6 months beforehand, if I had pointed you in the right direction, maybe you never would have gotten, right? Or same thing with the diabetes. You're 32 years old. This is what you're doing metabolically. There's not a great code to say that I've just had somebody who was overweight and I gave him practical advice. But I don't get paid to do that in the conventional insurance reimbursement world. Yeah. And we were talking in between the break there about most people, they're busy. They got to take time off work to come to see me or you. They'd like to get everything all done all at once. But I can only bill for doing so many things on one day. I can't do prevention and treat their cold on the same day and get paid for both of them. I got to pick one, right? You can't do an exam sometimes, determine what the problem is, treat the problem, treat it in one easy step, and get paid for that. They're going to deny that claim. Yeah. Or they're going to say, well, we'll only pay you either to examine the patient or to fix the problem unless you send them back home and bring them back 24 hours later, then you can get paid for both of the things that you've done for that person.
Yeah, it's a crazy model.
Right, and it's not good for that person who has their own busy lifestyle. That turns them into a patient instead of an active whole person that had this little problem that they came in and they got fixed in one day, right? They become a recurring visitor, a revenue generator, right? That's what happens in the conventional practices, because that's what the third-party payer systems has dictated the payer measures. We're going to say when we're going to pay you, how you're going to pay you, what we're going to pay you for, and it's the things that we think are important, not the things that you as a physician think are the most important thing that the patient needs that day.
Exactly. I had a friend that was diagnosed with MDS, myoplastic syndrome, and he was told, well, there's nothing we can do for you till you develop full-blown leukemia, and there's no treatment. If you live long enough to develop it, then we can treat it. And I sent him on his merry way.
Off you go.
And he calls me up from the parking lot of the physician's office and told me about this, and I said, okay. I said, what do you want to do about it? I said, well, there's nothing I can do about it. So it's like when somebody tells you you have cancer, and I expect you to be, you have 3 to 6 months.
Yeah.
What do you got? Expiration code on your forehead or something? So I said, well, Jim, you can change this, you could do this. Oh, well, nobody knows who Jim is, but anyway, you could look into these supplements, and you can, so we guided him, didn't have MNDS anymore. And Cleveland Clinic confirmed that he had MDS. His physician claimed that he had MDS. When he went back and all his blood work was great, he said, oh, we must have misdiagnosed you. But I'm only telling that story because Jim will watch this and he'll get a chuckle out of it. But the problem was, and the reason I brought it up was, he had a disease process, but because there was no billing code, there was no treatment. If you live long enough until we get a billing code, is basically what they were saying.
Right.
It was just scary.
Yeah. Well, I think though it also illustrates another problem right now. Is that, right, I found as an educator, when you educate somebody who's open-minded, who's able to say, I don't know everything, right? It's so easy, the educational process. But when somebody's head is already so full of knowledge in themselves and everything like that, it's almost impossible to teach them everything new. And I think that that's a frustration that patients bump up against in the conventional medical model a lot, is you get this hierarchy, this physician that is the great specialist that knows everything, doesn't have time to listen to the patient anyways, and maybe already knows too much to put anything else new in, right? So as you said, the physician's like, oh, you're working, you're cured. Well, there's probably like 30 other people just like you that I said wasn't going to be cured that didn't have the savvy to figure the things you out. But no, I don't have time to figure out what you did that might have helped these other people.
I could help all these other people. Yeah, exactly.
And for me, that has been one of the beauties of practicing concierge medicine. I typically spend a half hour to an hour in every time I see a patient, even if I'm seeing them for a cold that the old business would have had me taking care of them in 5 minutes so I could catch up on the rest of my schedule, right? Yeah. But I spend that time with them, and as I talk to them and I learn things about what they're doing and their life and changes they've made, I can share those with the rest of my patients. The American Medical Association will say, we don't want these direct primary care physicians. We don't want these. They're going to exacerbate the physician shortage. If I couldn't practice medicine this way, the way that I love to, I wasn't staying on the conveyor belt watching things drop off, right? So first of all, for the several hundred people I take care of, they would be still in that model anyway. So that's, plus I feel that when as an individual physician, just like when I was working in Greene County with my good friend Carla Franks, nurse practitioner, and we were educating the population down there, and we saw the population health improving, that was rewarding. That I can do. And guess what? If people are a lot healthier, if they're more empowered to take charge of their health, pay attention and evolve their intuitions about what foods they should and shouldn't eat, what supplements benefits their body specifically, maybe you don't need as many doctors.
See, I think what the average patient doesn't realize is a good physician takes your patient to heart. Mm-hmm. And I think patients see you come in and you do a treatment and they're forgotten about, they're on their merry way out the door. And it actually bothers us when there's a problem and it's difficult to resolve, and sometimes it's difficult because of compliance from the patient and so forth. There's all those issues. But really, when we're successful in treating a condition and that condition is eliminated, we actually sleep well that night.
Right.
And
right.
People don't realize that.
Right. Well, and this is the thing. When I was in medical school, it was against the rules to be overinvested.
Yeah.
Like literally, they were teaching us don't care so much about your patients.
That's tough.
And well, and we're seeing the results of the education process that I was getting 20 years ago. They also said if somebody really has pain, they can't get addicted to opioids.
Hell yeah. We know that story.
Like, listen, it has nothing to do with people's personalities. Like, some people are more vulnerable than others, but at the end of the day, opioids are addictive substances in and of themselves. They change the brain. Things will happen, and we can't hide our head in the sand about that. We have to be very judicious and very wise, and again, inform that patient of the risks and the benefits. Don't, when they come and say, I have pain, oh, here's a script, 2 minutes, I can go see the next patient, right? That's the wrong process. That got us into the opioid epidemic because we bought into a lie that was being propagated 20 years ago.
We were told that this is the way it was.
Yeah, this is the standard of care. This is the right way to do this.
And sometimes if you violate that standard of care, you get yourself into trouble, so you have to watch that. Mm-hmm. You know, I had a patient come in who wanted her teeth extracted because she lost bone, lower teeth, and she'd been seeing a dentist for a long time, and he said, we get them out, and she came to get them out. And I said, you know what, let's try something. Let's bond these teeth. You got to brush better and floss better, but we bond the teeth and like make a temporary bridge. Mm-hmm. And I want you to start taking vitamin D3 and vitamin K2, and let's see what happens. If it doesn't work, you can take them out later.
Right. But we can't put them back if we take them out today.
6 months later, X-rays, bone regeneration.
Wow.
And I'll see a lot of patients coming and say, well, I'm taking cholesterol medications. Did your physician tell you to take CoQ10? Never heard of it. Never said anything. Well, sometimes physicians say things patients don't hear or remember, but I see that a lot. So I try to do that in a practice because it's that education, you know. Yeah. And vitamin K2, all these things are so important for our general health. But I want to get off my tangent here.
Okay. I was enjoying your tangent.
Yeah. Let's talk about part of your practice that we haven't talked about, and that's skincare.
Okay.
So what is skincare within the realm of your practice?
That's the fun division of the practice. Well, it's all fun, but that's the part where I think, again, I'm very whole person. We get up in the morning, we see our face. I became a little bit intrigued about acne scars and other things that people see in their faces disfiguring and they get down about. And again, we live in a great time for so many reasons. One of them is this amazing technology with fractional laser resurfacing that can really repair those acne scars and a number of disfiguring scars. IPL technology, intense pulse light therapy, that can eliminate brown spots. Solar Lentigo is the most effective treatment for rosacea, which most people don't have access to because they're not told about because the insurance doesn't reimburse for it, even though it's less expensive to get 3 IPL treatments that will give you more than a year's substantial improvement on your rosacea instead of paying all these copays for the topicals to treat rosacea that don't even really address the problem.
And that's something that I think the insurance companies don't realize, that prevention or other forms of care can save them money.
Right.
It's something that, you know, is a really hard message to get across to the insurance companies. LPL is laser? IPL is laser?
Yeah, it's a form of laser.
So are you damaging the tissue with it initially, causing a little bit of inflammation?
A little bit. In IPL, we're specifically targeting over-pigmented skin that's darker than the surrounding skin.
Caused by sun damage?
Usually sun damage, almost always sun damage. But it also can, the pathological disrupted red blood vessels that, you know, can be purple or red on the face, it can also be set to target those things.
Is this a painful situation?
You know the answer to that, right? So we do topical numbing to make it as comfortable as possible. It feels very much like a rubber band being snapped against the skin, and you're done in 15 minutes, and you have all this improvement that goes with it. It's amazing, wonderful technology.
And then you have other collagen building processes as well?
We have the TempSure, which is radio frequency skin tightening. It's like getting a hot stone massage, but at the same time we're inducing repair mechanisms into the skin, improving the blood flow and the circulation. We hold the temperature, this is fascinating, between 102 and 104 degrees for 5 minutes, and that is enough to tell the skin that it needs to repair stuff. So it turns on all the repair mechanisms, has a very rejuvenating effect. If people have a temperature done, we usually recommend 1 temperature for every decade that person is old. So if somebody's 45 years old and they'd like to look 4 or 5 years younger, we can do a temperature once a month, 4 times, and they look 4 or 5 years younger. It's absolutely amazing.
We're at the end of the show. Thanks so much for coming on. Dr. Plute's going to be on the Dr. Ed Show, the radio show, on 12:50 a.m. on, let's see, we're May 20th, Saturday, May 20th.
Okay.
And that's at 9 o'clock. And that'll be archived also on rumble.com, where you need to search, subscribe, and what's the 3 S's? Search, subscribe, and share. Hey, remember, a healthy pet is a happy pet. When you're healthy, you're happy as well. God bless. We'll talk to you next time. Bye.